Hello, my name is Anne-Marie Kopinski. I am the president of North Country Vascular Diagnostics and also a clinical associate professor of radiology at Albany Medical College in Albany, New York. And today I'm going to be speaking on transcranial Doppler. To begin this discussion of transcranial Doppler, we'll start with anatomy, and that's important, obviously, to understand what we're looking at. Certainly, we all know about the Circle of Willis, and that was named after, indeed, Sir Thomas Willis, who first described it back in the mid-1600s. And the Circle of Willis is comprised of 5 components, and you can see them listed here. The terminal portion of the internal carotid artery comes up and actually branches. One of the branches it feeds into is the anterior cerebral artery, which extends and communicates with the anterior communicating artery, forming the anterior part of the Circle of Willis. Along the posterior aspect is the posterior communicating artery and the posterior cerebral arteries. This diagram better shows the orientation of these vessels. We can see here is the terminal portion of the internal carotid artery coming up, and we know the large branch here is the middle cerebral, but that's not really part of the Circle of Willis. The Circle of Willis here is comprised of the anterior cerebral, and again anterior communicating, as well as the posterior communicating leading back to the posterior cerebral, and we'll talk more in detail about all these vessels. The internal carotid artery, or ICA, comes up, and when it enters the cerebral portion, it branches into 2 main branches, the anterior cerebral and the middle cerebral. The middle cerebral, of course, is the largest, and the ICA also gives rise to several small vessels. An important one, of course, is the ophthalmic artery. The ophthalmic artery is shown here in this diagram from Gray's Anatomy. You can see over here the distal portion of the ICA coming up, and this is the first branch of the cerebral segment of the ICA. It comes up, coming into the back of the eye, and gives rise to several small branches. The important part here is the flow direction would be coming from the ICA into the eye. So if we were insunating through the orbit of the eye, which we do during transcranial Doppler, we would see that flow coming towards us. Another important aspect of the ophthalmic artery is that these small branches here can collateralize with distal branches of the ECA, namely the superficial temporal and the facial. Now, the middle cerebral artery really has a big job to do. It supplies all the circulation, really, most of the circulation, to the lateral aspect of the cerebral hemisphere. There are several segments of the middle cerebral artery. They're really not important. They're designated actually, though, as the branches form. For this discussion, we'll just call and talk about the middle cerebral as one vessel, even though obviously there are many branches. It is really the most common site of trouble for us in that it can often have the stenosis occur at the middle cerebral, as well as an occlusion from an embolic event, and it also can get aneurysmal disease. Now, there are many anatomic variants with the Circle of Willis. Hopefully, most patients have an intact Circle of Willis, but sometimes the anterior communicating is absent, sometimes the posterior communicating is absent or hypoplastic, and either posterior or anterior cerebral vessels can be absent or hyperplastic. When those events occur, other vessels may dilate in response to missing segments. And it's obvious that if there was an embolic event and circulation was cut off to one branch, that collateralization around the circle from the other side of the brain is important to obviously maintain perfusion and prevent a stroke. Now, when we talk about transcranial Doppler, let's talk about the equipment for a second. We need a low frequency transducer so we can get good sound penetration and not run into too much trouble with attenuation, because we are fairly deep and we need that power to transmit through the bone. There are certain windows in the cranium that allow us to penetrate and get some information. And transcranial Doppler really is all about looking at velocity and direction of flow. Now clinically there are multiple applications for transcranial Doppler. Looking for intracranial vascular disease, vasospasm, monitoring children with sickle cell, looking at collateral pathways, detecting emboli, various monitoring during procedures, and we can also use TCD to look for patent foraminal valley, which I'll talk about in a little bit, and also to aid in the confirmation of brain death. Now, as I mentioned before, there are several windows through the skull that allow us to see in and insonate these vessels. And this diagram is borrowed from a book chapter by Myra Katz, who's pretty experienced in transcranial Doppler, and there are really four main windows. The transtemporal window here is illustrated by letter A, the transorbital through the eye, through the foramen magnum as shown in C, and the submandibular approach. And depending on what view we're looking at, is you'll see the different vessels. As we come in from the side, we're going to be really close to the MCA and the ACA. If we come in posterior through the foramen magnum, of course, we're going to be seeing the vertebrals and the basilar here. From the transtemporal window, as I said, looking at the diagram here, the bone right in through here is thin enough. And as we come through the bone, we actually do see part of this brain here. And there are landmarks that we use to localize, but some folks have temporal bones which are just too thick, too dense to allow the ultrasound to be transmitted through adequately. And this is actually can be found in up to 25% of the population. So again, from this window, what are we going to look at? We're going to look at the middle cerebral, as well as we can see the anterior cerebral, and posterior cerebral and posterior communicating. From the posterior aspect here through the foramen magnum, the suboccipital window, we use the foramen magnum and we can see the right and left vertebral as well as the basilar. But from this approach, those vessels are actually going in, bringing blood to the posterior part of the brain, so we normally see the flow direction away from us. Through the eye, when we look, we see the ophthalmic artery. We can also visualize the carotid siphon, but we must be careful here and reduce our power output. That's essential so that we don't cause any potential damage to the retina. Here's a view here. We can see the globe of the eye right here, and we can see these are probably ciliary arteries along the back of the eye, and way back down here is the ophthalmic artery. And again, that's going to be coming off the ICA, which is out of the picture, deeper here, coming up and giving branches or giving rise to all the branches that support the eye. So normally flow direction is towards us. We can see that. It's color coded red. It's a positive Doppler shift. This is a normal flow orientation in the ophthalmic artery. And again, transcranial Doppler is one of those areas where we really have to pay attention to our power output and remember bioeffects that can and do occur with ultrasound, and we need to just do this as quickly as possible, put our power levels as low as possible, and remember the rule of ALARA, as low as reasonably achievable. There are two primary techniques for transcranial Doppler. There's the blind Doppler technique or transcranial imaging, which utilizes ultrasound images. The blind TCD technique can be accompanied by M mode as found on many of the newer pieces of equipment. In general, most of the time we look at mean velocities with the intracerebral or intracranial vessels, and we need to know what sampling depth we're looking at. If we're using duplex ultrasound and we're doing imaging as well, we always leave the angle correction set to 0, and that's by standard convention. Sample volumes are usually wider than the vessel. That's obviously so we can find these small vessels and achieve good sensitivity without reducing or with keeping the signal to noise ratio at a minimum and reducing the background noise. But because the sample volume is large, we'll get spectral broadening that will occur, and we may get more than one artery displayed. We use mean velocity, as I mentioned, over peak, because mean velocity is less affected by heart rate, contractility, peripheral resistance, and it correlates better with the overall perfusion to the brain. Here we have an image coming from a transtemporal approach, as we can see here. And in order to figure out what vessels we're looking at, we need to know what window we're looking at. So if you have a standard protocol, that needs to be documented, or if you're evaluating, some information should be displayed for the interpreting physicians. And we'll go by the depth of the vessel, what direction the flow is appearing on color, if we can trace back or track back that vessel, and we're going to use that all with both modalities as well as the image when we're using transcranial imaging. Here again is just showing an approach through the temporal window where we're going to see our MCA, and here's the duplex image showing the same thing with our pretty wide sample volume size, but we're seeing this nice middle cerebral artery. Tracking down a little bit deeper through the same window, we now see we're just coming up to where the anterior cerebral comes off. And now the flow direction's changed because that vessel is bringing flow towards the center, towards the midline. The colors change to indicate a negative Doppler shift, as well as the spectrum. Going and pivoting back slightly, as you can see from this view, we're still transtemporal, but now we've just angled back because we want to try to catch that posterior circuit, and we can see the posterior cerebral artery coming towards us. You almost never appreciate the posterior communicating vessel, which would obviously lie somewhere in between these two segments. Coming up through the foramen magnum, again, we see the basilar artery fairly deep. It's going to be the deepest vessel that we're going to be looking at here. And we can see in this example, actually, we're catching both vertebral arteries coming together to form the basilar, and again, very deep, very far away. And here's another illustration of that just in color alone. So how do we diagnose what we're seeing, and how do we appreciate what vessel we're in? Again, we're going to look at the vessel depth and the flow direction. The velocities are usually the highest in the MCA because that is a large vessel, and they gradually taper as we go down and out the vascular tree. You can see from a transtemporal approach, the middle cerebral is going to be the most shallow at a depth somewhere between 30 and 60 millimeters. As we go a little bit deeper, we'll come to the junction of the middle cerebral and anterior cerebral. A little bit deeper, we'll see just the anterior cerebral, and again, if we pivot back towards the back part of the brain, we'll pick up the posterior cerebral. Through the suboccipital window, again, it's the vertebrals and basilar. Vertebrals are what we're going to see first. The basilar is going to be the deepest, anywhere between 8 and 12 centimeters. And as we see, the velocities are pretty much the same in the range of around 40 centimeters per second. And again, the flow direction normally is away from us. Through the eye, pretty much the main vessel we're going to insonate through the transorbital approach is the ophthalmic. It'll be a little bit variable in terms of the depth, between 40 and 60 millimeters, should be coming towards us. And as we look a little bit deeper, we can pick up the carotid siphon, but depending on that, where we are in the siphon, the flow may be towards us or away from us or bidirectional, because remember, the vessel takes a series of turns in this region. And from the submandibular window is primarily what we're going to use to evaluate the ICA. Power Doppler can be useful. Obviously, it picks up lower flow, and it's a little less angle dependent. We can see that in this image here. If we inject contrast, we can see how much it enhances, and we can pretty much see in this example the whole circle of Willis. Now, just another couple of examples here is the middle cerebral artery again. So we've got a pretty good sample volume. We've got no angle correction on. We're at a depth of just about 6 centimeters here. which is about where we would expect it, and we see nice normal looking waveform. Well, how do we diagnose disease? Well, stenosis in the intracranial vessels is going to appear just like a stenosis anywhere else. We'll see this focal increase in velocity, we'll see turbulence at that site, and we'll see a post-stenotic change in the waveform, a drop in velocity and some turbulence. We should expect that in general, if we see a greater than 50% stenosis, is consistent with a doubling in the mean velocity. Just like we do in the periphery, where a velocity ratio of 2 to 1 is a 50% stenosis, it's the same here. We do have some general thresholds for the middle cerebral artery, which we'll talk a little bit more about later, but around 100 is a good number to remember. Well, stenosis is a problem, but vasospasm is probably the problem we see most of the time. And it can occur in any of the intracranial arteries, and it usually does follow a patient who's had a stroke due to a subarachnoid hemorrhage. As the blood leaks out, the body realizes that that blood is not supposed to be there. It reacts. It causes vasospasm within the vessels because the body, again, senses that there is blood outside the vascular system, and it wants to shut that down to prevent further leakage occurring. Middle cerebral, anterior cerebral, and posterior cerebral are the most common sites for vasospasm. And here, and we're going to run this video here just to show you the velocities that we can see with a live vasospasm. We're peaking out over 300 centimeters per second. If you could hear the audio, you would hear the high-pitched sound that would go along with a PSV, as you would expect, of 300. When neurologists look for vasospasm, they're hoping that they can see these increased velocities that help predict the onset and precede the onset of symptoms, so they can help better manage. There are temporal changes that go on in these intracranial vessels. It doesn't happen immediately after a subarachnoid hemorrhage, but can happen about day 3 or so, 3 or 4. Velocities can increase at about a week and then generally resolve in 2 to 3 weeks. Most places that do this type of monitoring repeat the transcranial Dopplers every day for a routine interval of probably 7 to 10 days or more. This table just shows some criteria for vasospasm. We can see in general a moderate vasospasm is within a vessel that displays a velocity, mean velocity again, of greater than 120 centimeters per second. Severe vasospasm is associated once the velocities are above 200, and we can see down here in the lower right a vessel again with velocities well in excess of 300 centimeters per second in severe vasospasm. How do we tell stenosis from vasospasm? Again, vasospasm is not going to be focal. If we have a stenosis, it's really going to be focal, and vasospasm actually can be triggered in multiple vessels within the brain. And as I said, these are dynamic and will change over time. Now, another area that we use transcranial Doppler, transcranial imaging, is the monitoring of patients with sickle cell anemia. Here, patients that have distorted red blood cells associated with sickle cell can also have problems with getting that blood through and into the portions of the brain necessary, obviously, that have good perfusion, and cerebral infarction can be seen in these patients and often quite devastating as they are usually younger in age. It can occur in the distal ICA and middle cerebral artery as well. And if something is detected and an event is detected where these high velocities are recorded, appropriate therapy can be intervened and certainly can be helped with the arterial imaging. We use just a little bit higher velocity criteria for somebody who's borderline abnormal. We use a value of 170, but again, once mean velocities in the MCA get above 200, it is associated with a sickle cell crisis. Now, transcranial Doppler is used in a variety of methods to do various monitoring, and this just lists a few of them, looking at changes during various operative procedures. It also can be used to look for a patent foraminal valley, which has become quite common. Various embolic events can be monitored with transcranial Doppler. And you'll see that we see this distortion here on the Doppler image with lots of spikes, and that is real. That is not due to a gain artifact. These are just high intensity waves that come through, and they're higher intensity compared to the surrounding blood. So you'll see this type of very classic appearance on ultrasound, as well as you'll hear this chirping kind of sound, and very distinctive, and these are referred to as hits, high intensity signals. And we'll just show you these images here. This is a heart with agitated saline, some bubbles going through. We'll play that again. You can see the bubbles kind of going through the chamber, and we're doing monitoring, transcranial monitoring, and we're looking for those hits. We're looking to see if some noise comes through and timing this out. And we start to see a little bit, and here's a lot more. These are the hits, these bright spiky lines that we're appreciating here. And I'd like to thank Bill Zhang for giving me these loops, and here we can see some of that coming through again. Also with transcranial Doppler, without the imaging, same thing. We can still see, we see the various displays here, and this is all the hits. It's not noise. This is all the emboli coming through, whether it's emboli from a procedure, or in this case, this is emboli induced by giving some sort of bubble or agitated saline to detect, in this case, patent foraminal valley. And this equipment actually counts the hits for us, so we can find out exactly what's going on. Another purpose for transcranial Doppler is basically used to confirm brain death. Brain death, of course, is a clinical diagnosis. It's not going to be made by transcranial, but transcranial will be used to detect what the cerebral circulation is looking like, and obviously can help aid timing of additional tests, and also potentially help prepare a patient who might be a potential organ donor. And we can see these transcranial Doppler signals showing very high resistance flow, pretty much no flow through diastole. And we would check and make sure that this sort of oscillatory pattern persists for several minutes, usually up to, at least a half an hour. And this is just not enough circulation getting in to that tissue, and again, associated with brain death. Now, the very interesting aspect of transcranial that we'll finish up with here is the application of transcranial Doppler in a therapeutic modality. There have been several papers. Dr. Andrei Alexandrov has published extensively on this, and there are some clinical trials. And basically, what happens is they use the intensity from a transcranial signal to help get thrombolytic agents through a clot. Here's just a diagram of a clot. We can see the red blood cells, and we can see the fibrin here. And it's described to me oftentimes as the mechanical pressure wave from the ultrasound. It's kind of like a breeze blowing through a curtain, and this fibrin web is like the curtain. The mechanical pressure from the TCD is sort of like blowing this fibrin web around and around, and as such, it's exposing more of this material through, to the thrombolytic agent, and people see things resolve a lot more quickly. And I would suggest checking out any of these publications to get further information, but it's a great therapeutic application of TCD. Now, of course, any test has some limitations. TCD is extremely operator dependent, such as most ultrasound, but it's pretty tricky. We have to have good equipment. Sometimes we're limited by patient movement. We certainly need a technologist or sonographer with a steady hand. And as I said, in some patients we cannot get proper windows, and it does take a lot of time to get a complete study. So in summary, I think the success at doing TCD is to be familiar with anatomy, understand the vessels, understand what depths those vessels are at, what direction the blood should normally be going in, and that will help as we obtain the Doppler signals. There are multiple clinical applications for transcranial Doppler, and it's expanding all the time, and it certainly has expanded recently to include surgical and interventional procedures. And lastly, don't get a royalty from these folks, but if you have information or need information and have the desire to learn more about transcranial Doppler, I would recommend this book by Myra Katz and Andrei Alexandrov by Summer Publishing. It's a wonderful textbook and gives you quite the overview for transcranial Doppler. Thank you very much.